Welcome to another important video on gastrointestinal system, hormones and regulatory substances. And also we are going to cover a series of videos that will cover the regulation of feeding and energy expenditure. There are multiple learning objectives. In this video, we are going to mainly focus. There are four important hormones, that is a gastrin, secretin, cholecystokinin, gastric inhibitory peptide. In the next videos, we are going to cover rest of the things. All right. Okay. So the gastrointestinal peptides, this includes hormones like neurokines and paracrines. The mainly that regulates the functions of the gastrointestinal tract. So the functions mainly the contraction, relaxation of the smooth muscles and sphincters of the gastrointestinal tract, and the secretion of enzymes for the digestion, secretion of fluids and electrolytes. The fluids and electrolytes we covered in another video. You can watch that, water and electrolytes. And also these hormones mainly important for the growth or tropic effects of the tissues of the gastrointestinal tract, and also regulation of the secretion other gastrointestinal peptides, for example somatostatin, so that inhibits all the secretions of the gastrointestinal hormones. What are the characteristics of these gastrointestinal peptides? So for example, hormones, these are secreted into these are peptides released from the endocrine cells of the gastrointestinal tract. They are secreted into the portal circulation and pass through the liver and enters the systemic circulation. Then they target the cell. So that is the hormonal pathway. So any hormone, these especially the four hormones in the beginning we mentioned, they mainly qualify this pathway. They secreted and release, enter into the circulation and goes to the target cell. In contrast to paracrine cells, so these paracrine cells locally within the same cell, same tissue, they secretes them. The paracrine substances reach the target cell by diffusing short distance through the interstitial fluid and carried short substances. Whereas the neurocrines are substances that are synthesized in neurons of the gastrointestinal tract and released following the action potential. After release, the neurocrine diffuses across the synapse and acts its target cell. So that hormones mainly they met the criteria like a gastrin, cholecystokinin, CCK, secretin, and GIP. GIP, gastric inhibitory peptide, also known as glucose dependent insulinotropic peptide. Whereas paracrines, these are somatostatin and histamine, so they are like paracrine effects. Whereas neurocrine, so these are like neural regulated like acetylcholine, norepinephrine, vasoactive intestinal peptide, nitric oxide, gastrin releasing peptide GRP, bombesin, enkephalins, neuropeptide Y, substance P. The gastrointestinal hormones, the hormones must meet the criteria of these three things. Number one, the substance must be secreted in response to the physiological stimulus and be carried in the bloodstream to a distant site where it produces its physiological action. That's number one requirement. Number two, its functions must be independent of any neural activity, and it must have been isolated, purified, chemically identified, and synthesized. After applying all these criteria, the only there are four hormones met this criteria. Those are gastrin, cholecystokinin, secretin, and gastric inhibitory peptide. In addition to this, there are several candidate hormones. They won't meet all the criteria, but they met something among these three, like motilin, pancreatic polypeptide, somatostatin, 5-hydroxytryptamine, ghrelin, leptin, glucagon-like peptide 1 and 2, GLP-1 and 2, enteroglucagon, peptide Y and Y, neurotensin. So they met some of these criteria. So that is why these are called as candidate hormones. So these are primary hormones. These four are primary hormones. They met these three criteria. All right, the first important hormone, the gastrin. So gastrin is important hormone because especially the gastrin, when you see in the gastric gland, so in the stomach, so you can see these gastric pits, and also you can see this photographic picture of the gastric mucosa with the immunohistochemical stain of the gastrin. So this is a deep within the gastric pit. So this is a brown discoloration. So that is a gastrin. So gastrin, where it is released? So it is a peptide hormone released from the G cells of the gastric pits of the antrum of the stomach. All right. So we know that in the stomach, you guys learned multiple times. In the other lectures, like parietal cells secretes gastric acid, that is the H plus ions, and hydrochloric acid, and intrinsic factor, right? So we know that intrinsic factor is important for vitamin B12 absorption. So vitamin B12 binds to intrinsic factor and absorbed in the terminal ileum. So that's why when the patient have gastrectomy, removal of some the stomach, so there is a deficiency of vitamin B12. So that leads to pernicious anemia and some neurological problems. Whereas chief cells, they produce pepsinogen. Anything they end with nogen, that is inactive form, right? So you need the pepsinogen should convert into active form pepsin, right? So pepsinogen to pepsin is active. Then G cells, we know that there is a gastrin, that is a hormone. So gastrin, what is the functions of gastrin? Why you need gastrin? So gastrin is important to digest the food, right? So because it increases the secretion of gastric acid, so that increases the digestive enzymes like pepsinogen and intrinsic factor, gastric acid. All these are important for the digestion of food. And also the gastrin stimulates the motility, right? So it helps to uh, mix the food and disintegrate the food and acidify the food, and also enhances the motility, propels into the duodenum, and also stimulates the growth of gastric mucosa and stimulates the enterochromaffin cells. So that these cells, it stimulates the gastrin, stimulates the ECL cells, so that releases the histamine, and histamine stimulates the hydrochloric acid, HCl, right? So we know that in the stomach, so we know the H plus potassium ATPase pump, correct? So that the H plus ions release into the lumen and potassium goes into the cell, right? So that H plus ions increases the acidity, all right? So that is the basis of whenever you have increased too much of gastrin, that leads to what? It causes gastritis, right? So it may cause ulcers, it may cause damage to mucosa, right? So that's what you can use some of the medications like H2 blockers. So especially in the stomach, we have histamine 2 type receptors. So that's what the ranitidine. So ranitidine, famotidine. So these are H2 blockers to help to reduce the acidity in the stomach in the case of gastritis. All right. And also, the gastrin releases the pepsinogen and intrinsic factor, and we know that the vitamin B12 absorption, the intrinsic factor is important. The gastrin release is stimulated by stomach stretching, stomach distension, and also amino acids like phenylalanine, tryptophan, and calcium. And vagal stimulation. Vagus means the cranial nerve 10, that is the acetylcholine mediated, right? Muscarinic receptor stimulation that stimulates the G cells, so that releases the gastrin release peptide, so that releases the gastrin. So when you recollect your the anatomy, histology knowledge about the gastrin, so if you see the various cells in the stomach, so this is the surface epithelium and the mucous cells and parietal cells and chief cells, and here is the enterochromatin cells. Okay, so this is the lumen, the gastric pit, and also the upper glandular layer and deep glandular layers, right? So here you can see all these glands, and this is the submucosa. This is submucosa, and this is the muscularis mucosa. All right. All right. So while talking about the gastrin, so talking about the Zollinger-Ellison syndrome is a very important. So Zollinger-Ellison syndrome is a condition due to tumor that releases massive amounts of gastrin. So this increases the gastric acid that may damage or erodes the mucosa that causes ulcers, mainly the recurrent duodenal ulcers. And the patients usually seek the medical attention for severe peptic ulcers and the gastrin secreting tumors like gastrinoma, right? So especially when the patient have the gastric ulcer, duodenal, so most of the time we have to look for the causes. Like what are the causes? Maybe non-steroidal anti-inflammatory drugs, painkillers, they may cause ulcers. Or H. pylori, most of the time you have to test for H. pylori, right? So of the population of in the world they have H. pylori infection, but only some people they end up with the symptoms, right? So because of the virulence factor, like a CAG virulence factor, so that the H. pylori usually stay in the acidic environment. It liberates the ammonia, urease enzyme. It creates the ammonia. It makes the alkaline environment surround the H. pylori harboring area, and it anchoring to the epithelial tissue of the gastrointestinal tract. It slowly erodes the mucosal layer, right? So that's what the eradication of H. pylori is very important if the patient is uh, positive for H. pylori, or if it is a gastrinoma. So we have to treat the proton pump inhibitors. The proton pump means so H plus potassium ATPase is a proton pump. So PPIs we call it as a proton pump inhibitors like omeprazole, rameprazole, rabeprazole, esomeprazole, or we can use the octreotide, so somatostatin analog, especially in the gastrinoma. And also, in addition to ulcer, there is a steatorrhea symptoms also present in the Zollinger-Ellison syndrome because of the low duodenal pH that inactivates the function of pancreatic enzymes, especially lipases. So then patient cannot digest the fat that leads to steatorrhea. So especially the tumors can arise from in the stomach, duodenum, or pancreas. So most of the gastrinomas are sporadic. So but 20%, 25% are part of multiple endocrine neoplasia, MEN type 1. All right. So if you see in the radio contrast CT abdomen, so you can see the tumor here, circular. So that may cause the massive amounts of release of the gastrin. Whereas in the histopathology, so you can see the clusters of various the tumor cells. So these are hyperchromatic nuclei and nuclear irregularity, loss of nuclei, less cytoplasm, right? So this is a classic finding of the Zollinger-Ellison syndrome or gastrinoma. So this is the, the gastric and duodenal ulcers. There is a lot of bleeding is going on. So this is the endoscopic view of a large gastric ulcer. So when you compare the gastric ulcer and duodenal ulcers, so most of the time the H. pylori infection, you can see the 70%, here 90%. So that's the first thing you have to differentiate. So you have to check for the H. pylori infection, right? Then mechanism. So what happens in the gastric ulcers? So there is a decrease mucosal protection, so that leads to aerosol, so that may cause mucosal damage. The same thing both gastric and duodenal. Whereas a major cause in the gastric ulcers, especially the NSX, whereas a duodenal ulcer, Zollinger-Ellison syndrome and H. pylori, right? And so especially the risk of carcinoma is a gastric is a very increased. So whereas a duodenal ulcers, generally the benign thing, all right? So not routinely biopsied, the duodenal ulcers. All right, so pause the video, list three stimulants for gastrin secretion and what are two functions of gastric. Once you have answers, then restart the video. All right, I think you got the answers. The three stimulants for the gastrin secretion, the stomach distension, the phenylalanine, tryptophan, calcium, vagal stimulation. The functions mainly the gastrin increases the secretion of gastric acid, digestive enzymes in the stomach, stimulates the release of pepsinogen and intrinsic factor. All right, another quiz. What condition is associated with increased gastrin? So that is the Zollinger-Ellison syndrome, duodenal ulcers, gastric ulcers. There is increased gastrin. All right. So next hormone is a cholecystokinin. Cholecystokinin, CCK. So you can see the name chole. Chole means that is from cholesterol. So the bile is formed by the cholesterol, right? And cysto, right? So cysto means sac-like, right? So that is a gallbladder. And kinin means movement. Cholecystokinin is important for the gallbladder contraction and relaxation. That's the meaning, all right? And here you can see the immunofluorescence of small bowel villi with cholecystokinin I cells highlighted in the green. So these are the cholecystokinin. All right, so these are scattered throughout the surface of the villi. So cholecystokinin is a pancreogymin. It is a peptide hormone produced in cholecystokinin cells, that is I cells. So remember cholecystokinin I for I cells, cholecystokinin I for I cells, whereas the gastrin G for G cells, right? Easy to remember, all right? And the lining of the duodenum, so these eye cells mainly present in the duodenum and jejunum in response to what is the stimuli? In response to monoglycerides like fats, fatty acids, small peptides, and amino acids. So what's the functions of cholecystokinin? There are five major functions of cholecystokinin, right? So by name itself, it is the causes the movement of the gallbladder, right? So that means it stimulates gallbladder contraction and relaxation, right? Of the sphincter of Oddi, that is the bile and pancreatic duct sphincter, and it increases the bile release. And the bile is why you need bile. Bile is important to emulsify the fat, right? Because the fat is not soluble in water. When you bile mix with bile acts as an emulsifying agent. Emulsifying agent means it reduces the interfacial tension from the aqueous phase and oily phase so that it mixes together, so that enhances the lipid absorption. Number two, it triggers the release of pancreatic digestive enzymes like amylases, lipases, proteases for the digestion of carbohydrates, proteins, and fat. and it inhibits the gastric emptying. So why? Because it gives some adequate time for the subsequent digestion and absorption steps in the duodenum and the jejunum. So you don't want a lot of dumping from the stomach to continuously to the duodenum, right? So it needs some time because it communicates the cholecystokinin with the gallbladder. It takes some time. So that's what you should not do. You should not eat continuously, correct? Secretion of bicarbonate. So that's another important function of cholecystokinin from the pancreas, because we know that the chyme is a very acidic. The it should be make it alkalized to enhance the pancreatic enzyme function, right? So secretion of bicarbonate and the growth of exocrine pancreas and gallbladder. Okay, so those are the five important functions of cholecystokinin. You must remember. All right. So we know that the stimulus is, that is the fatty acids, amino acids, and obviously acetylcholine is the vagus nerve, that is the rest and digest, right? So parasympathetic system is a very important for the gastrointestinal stimulant action, right? So parasympathetic means it stimulates all the gastrointestinal functions, rest and digest, acetylcholine. The next hormone is the secretin. The secretin is the pep, this is a peptide hormone. So it is a mainly released from the S cells of the duodenum. So when you see the photo micrograph of small bowel, the villi, so you can see these the brownish circled ones. These are the secretin released from the S cells of the villi of the duodenum. So it is mainly released as a prosecretin. So then it converts into secretin by activated by gastric acid. So secretin, the structure of secretin is similar to the glucose dependent in the GIP and glucagon family. It's related to the glucagon and GIP related family. The major function of the secretin, the secretion of bicarbonate, right? So think in the stomach is acid. From the duodenum, it is alkalized, right? So you need to make that chyme, make it alkalized. So that's what secretin, cholecystokinin, they stimulates the bicarbonate to alkalize that acidic food coming from the stomach, right? So that bicarbonate neutralizes the acid chyme in the from the stomach, so in the intestine, so that removes the initial stimulus, the release of secretin, right? And also the neutralization of the H plus ions, the acidity is essential for digestion, right? So especially for the pancreatic lipases, they should have the optimum pH between 6 and 8, right? So if it is not neutralized, then it is not activated. Then pancreatic enzymes won't be effective, right? So they are denatured. So that is why the secretin inhibits the effects of gastrin on the parietal cells so that it decreases the H plus secretion and growth. All right. And also the secretin stimulates the delta cells of Langerhans that release somatostatin that inhibits the secretion of pancreatic hormones, gastrin, secretin, cholecystokinin. All right. So the next hormone is the gastric inhibitory peptide, also known as gastric glucose dependent insulotropic peptide, and also it is enterogastrone hormone. So entero means intestine, right? So gastro means stomach. So enterogastrone. So it is a peptide hormone, mainly the GIP produced by K cells. So GIP is the structurally, chemically, it is a 42 amino acid peptide. It is a member of secretin glucagon family. So GIP has a 9 amino acids that is a common with the secretin, and 16 amino acids is a common with the glucagon. So because of this homology, the pharmacological levels of GAP produce the most actions of secretin, right? So the GAP is secreted from which cells? K cells. GAP from the K cells in the duodenal, jejunal, and ileal cells. And what is the function? What is what is the stimulus for the GAP release? So the GAP is released by three things: fatty acids, amino acids, carbohydrates. So, and also the oral glucose mainly stimulates the GIP secretion from the K cells via sodium glucose cotransport. SGLT1, we know that SGLT1 present in the gastrointestinal tract, right? So SGLT2 present in the kidneys because we have two kidneys, SGLT2. One GI tract, SGLT1, all right? And also this is a major important function of the oral glucose. So the functions of GIP is it is a weak inhibitory of gastric secretion and emptying, and also it increases the release of insulin from the pancreatic beta cells of the uh, pancreas. So especially when you take this oral glucose, that increases the GIP, that stimulates the pancreatic beta cells. So that is the one of the major difference. When you give IV insulin, only act on the pancreatic beta cells. When you give oral glucose, it acts both places. It increases GIP as well as it acts directly on the pancreatic beta cells. So that's what oral glucose is a predominant action on the insulin release compared to IV insulin. All right, so when you see the interplay of these four important hormones on the GI tract, especially the positive sign is the stimulation, the negative sign is the inhibition, right? So in the stomach, so we have a acidic environment, acid chyme. So in the stomach, you have the various cells like parietal cells, they produce gastric acid, uh, pepsin is produced by chief cells, bicarbonate produced by mucous cells, and intrinsic factor is produced by parietal cells. So especially if the person having a autoimmune gastritis, they destroy parietal cells, that leads to vitamin B12 deficiency. Okay, that's another important clinical point. And once you have that chymes enter into the duodenum, you have a release of cholecystokinin, secretin, and GIP. So whereas the cholecystokinin stimulates the bile and release the bile comes into the duodenum that emulsifies the fat and enhances the lipid absorption. Cholecystokinin also stimulates the pancreas, release the pancreatic amylase, lipase, and bicarbonate. Secretin also stimulates the pancreas to release the bicarbonate. All right. So this is another picture we are going to cover in the coming videos. All right. So four important one. Number one, gastrin from the G cell stimulates stomach distension, primary digested proteins, and increases the secretion of gastric acid. And number two is the cholecystokinin. The cholecystokinin is mainly from the eye cells and stimuli mainly fatty acids and amino acids. And cholecystokinin, just analyze the name. Chole means a bile from the cholesterol, cyst like a duct sac, and kinin is a movement, so gallbladder movement, right? So it mainly secretes the pancreatic enzymes, bicarbonate, contraction, the gallbladder relaxation of sphincter of Oddi to release the bile, decrease the gastric emptying, stimulates the growth of the exocrine pancreas and gallbladder. Number three, secretin, mainly from the S cells of the duodenum. The stimuli is the stomach acid, fatty acids, and stimulate the functions, secretion of bicarbonate, and triggers the delta cells and inhibits the tropic effects of the gastrin on the mucosa. The number four is the gastric inhibitory peptide GIP, that is mainly from the K cells. All right, whereas the secretin from S cells. So the stimulus for the GIP, the fatty acids, amino acids, and carbohydrates like oral glucose. The major exocrine functions of the GIP, it mainly decreases the gastric hydrogen ion concentration and decreases the gastric emptying, whereas endocrine, it increases the release of insulin from the pancreatic beta cells. So that is why oral glucose enhances insulin compared to IV due to GIP secretion. All right. So the reference is Costanzo, textbook of physiology, and some information from first aid and scholarly X will be continued in the next